Hello and welcome to the King's Fund and our first online event of 2020. I'm Helen McKenna, I'm a Senior Fellow here at the Fund and I'm going to be chairing this event. I think I'll be with you for the next hour or so. Today we're going to be getting out our crystal ball and looking at what's in store for health and care over the rest of the year and beyond. And we'll be covering a range of issues, including looking at what the results of the general election might mean for health and care, but also looking at what's coming up on the horizon for the health and care workforce, for social care funding reform, NHS funding and performance, and much, much more. But before we do, I'd like to first introduce my panel of experts who are here to answer your questions. So Sally, Susie, Siva, could you each just briefly introduce yourselves and say what you do here at the Fund? Sally, let's start with you.
Thanks, Helen. Good afternoon, everybody. I'm Sally Warren. I'm the Director of Policy here at the King's Fund.
Hi, I'm Siva Nandasiva, Chief Analyst here at the King's Fund. I work for Sally in the policy team, mainly on funding, finance and performance of the NHS.
Hello, I'm Susie Bailey. I'm the Director of Leadership and Organisational Development, heading up a team of leadership specialists who work out with leaders in health and care.
Thank you very much. So just a few points from me about how this session's going to work. So we've got an hour, as I said, and we'll begin by asking Sally, Siva and Susie to get the discussion started by just providing a few reflections. But we're going to use most of the time to answer the questions that you'll be sending in. So please do send them in as soon as you can. In terms of how to do that, you should see a box at the bottom of your screen where you can submit those questions. And as soon as you send them through, they'll come up on my screen and I can put them to our expert panel. And just a plea from me as chair, we've got over 2,000 people registered to view today. So I expect that you'll have lots of questions. If you could keep them as short and clear as possible, then we can try to get through as many of them as we can. And you can also join in and follow the discussion online on Twitter using the hashtag KF Online throughout the event. And finally, you should be able to see to the right of your screen some links to online resources that we think you might find helpful. So please take a look at those too. So I think that's everything that I needed to cover in terms of housework. So before we start our way through the questions, I'd just like to invite each of you to provide us with some reflections to help us get started. So Sally, let's start with you. Where are we now from your perspective, and what are some of the key things on the horizon that you think people should be looking out for over the course of 2020?
Thanks, Helen. So I'm going to mainly reflect on social care and public health today, which were two of the areas for the health and care system where the government was relatively quiet in the manifesto in comparison to their commitments around the NHS. So if I start with social care, I think a lot of people joining us today will absolutely recognise that that's a system that's been under real strain over the last decade with real funding difficulties, and that's really continuing. So the government has issued a one-year spending settlement for social care. It doesn't benefit from a long-term spending settlement like the NHS does. And it's had a small amount of additional funding for next year, but has just also now had to deal with a large increase to the national minimum wage. That's really welcome for our workforce in social care, but that's a very large cost pressure for our providers and local authorities that government hasn't yet said how they're going to fund. So I think in terms of the current means-tested system, it's going to be a really challenging year yet again. We also obviously have the long vexed question of social care funding reform, which in its manifesto, the government committed to cross-party talks. Prime Minister Johnson has talked about taking action on that in the first 100 days. I think it's clear to me that they are genuinely committed to wanting to solve the problem, but I don't think they have a plan right now. So hopefully this is the year where we do actually see some firm proposals and some discussions in Parliament around that. If I move on to public health and population health, this is even in an even more precarious funding position than social care, in that actually, unless they snuck it out this morning, the public health grant allocations for April this year haven't been issued yet. So we have local directors of public health needing to plan for services and not knowing their funding position in only a few months. So I think that's a real challenge in terms of practical delivery of public health. But I think in terms of the broader agenda for public health and population health, it's quite difficult to tell what this year will bring. So I think there'll be really strong innovation on the ground, but in terms of a government agenda around prevention and population health, and to what extent they'll really embrace wider determinants, or is this a government that will want to support more about individual empowerment and freedom than looking at the wider determinants? That is, I think, a real dilemma. One thing that is positive is the agenda around levelling up and bringing left behind areas further, reducing those inequalities. That would suggest a focus on wider determinants, so hopefully that will come over the course of this government, but whether it's 2020, who knows. And then finally, what's the thing that brings all of that together? That's integration, and I think this year obviously there will be a big focus on integration across health and care. So we're beginning to enter the final year where all areas need to move to integrated care systems. We have primary care networks developing, so I think there'll be an awful lot of focus at ICS level, at place level in neighbourhoods about creating the right relationships to really deliver joined up care.
Fantastic. And we're already seeing questions coming in on the issues that you've raised there, Sally. So,
Thank you.
But before we get into those questions, Siva, I'd like to come to you. So just a few reflections from you. I mean, I know you do a lot of work on NHS funding and NHS performance. I don't know if there's anything in particular you want to pull out in terms of what we're going to see in 2020.
Yeah, thanks. So on NHS funding, finance and performance, I think the first thing is there's some clear moments that are coming up. So if we look ahead to the budget in March, that's one big moment, big fiscal event. You've got the spending review that has to happen at some point in the year as well. And I think there are a few things here. As Sally said, the big unanswered questions over funding for public health, funding for adult social care, funding for education and training of the workforce, funding for capital projects, capital investment infrastructure, that all of which lies outside this new 5-year funding deal. So I think that's the first real sign of what the government's intent is in these areas, and also for other government departments. So is it really the end of austerity? So that's the first big thing, the fiscal events that send a signal about what the government's spending plans are. The second thing is, again in March, we've got Steve Powers, the Medical Director of NHS England and Improvement, who at the moment is reviewing the performance standards like how long you wait in A&E, how long you wait for a knee or hip operation. These totemic standards that have been with us for 20 years are under review, so that will be a big report coming. Again, that will signal what's the government's intent about how it will measure what the NHS is delivering. And the third thing, you know, I think there's a little bit of technocratic nerdery, but I can't resist. In April, we will move into a new era for financial management in the NHS. For those of you who are aware, there's been quite a tight grip on how finances are managed in the NHS, what's called the control total regime. Well, as we move into April 2020, there'll be an easing off of that regime and some trust going back to local organisations in the NHS to manage their own finances. So that's one thing, that you've got these big moments that are coming up. But against that, when it comes to funding and performance and finances, you've got the steady drumbeat of winter pressures, you've got making your cost improvement plans that run throughout the year, you've got organisations that are going to start thinking about what it means to manage their finances and deliver performance in a new system environment. So I think you're going to have, over the course of this year, a really weird dynamic of these big moments that are about new things, a new workforce plan, new funding deal, a new budget, a new government, and promises of more, meeting the steady drumbeat of pressure. So you could end up with this dynamic of where's all the money going and what are we getting in return for this investment?
Absolutely. Thank you for that. Susie, you're our Director of Leadership and Organisational Development. Yeah. I know you've done a lot of work on the workforce in particular, but so what's your view in terms of big things that our audience should be looking out for?
Okay, so through this discussion this morning, I'm going to be saying workforce. That's not a new issue for either the NHS or for social care, but the scale of the problem at the moment is a real issue in terms of delivery, in terms of quality, and also the cost. So we saw obviously in the manifesto the NHS being put as a high priority in the manifesto, and all of the political parties were putting NHS workforce in their manifestos. In terms of the NHS, more staff, so where are they coming from, how will they be trained, and in the Closing the Gap report that we did with the Health Foundation and the Nuffield last year, that identifies kind of more detail on this, but essentially the numbers are quite scary in terms of what actually needs to be in place in order to to reduce the gap. The NHS fundamentally needs to be a better employer, and in social care obviously we've got multiple employers and private sector employers, so what is it that employers can do, whether they're public or private sector, to actually retain the staff that they have? So working on culture, leadership behaviours, flexible working, a whole range of things. And fundamentally for both social care and the NHS, a workforce redesign. So doing more of what we currently do isn't going to close the gap. So what are the changes? And I think that's particularly pertinent in community and primary care. So how can integrated care systems and primary care work effectively together with the training institutions, with Royal Colleges, to actually really act on some of the recommendations that have been coming out. So I think, you know, people are passionate about workforce. It's not that people haven't been working on it. There's a lot of good work going on out there, but I think the sheer scale means that 2020 really needs to be a shift in focus. And whilst the targets that Siv has been talking about are critical and important, if we don't shift our emphasis on looking after the people who actually deliver care, then we haven't got a hope of achieving any of the things that either the government wants to do, people within the service want to do, and fundamentally that our local communities are demanding.
Thank you, and I'm sure we'll come on to some of the things you've highlighted there through some of the questions that we get. So thanks to the three of you for your very helpful reflections. Ahead of the event today, we put out a poll on Twitter asking people what's the big issue that they're hoping to see progress on in 2020. And the options were limited, so they were health inequalities, the NHS performance, social care and workforce. Before I announce the results, I'd like to ask, can the panel guess which one came top?
She showed me.
I'm going to say
you were meant to pretend, like, you know, do some acting.
Lucky it's not live. So I would guess social care.
I think that's a really good guess.
Thank you.
I'd be delighted if it was social care, because
Right.
actually I think lots of people in the NHS are telling us that as much as there's loads to do in the NHS, they'd really like to see much more cross-party emphasis on social care. So.
Well, I think we all know, and now the audience will, that social care did indeed come top. So, so I'm sure we're all pleased to hear that, because it is an issue that needs to progress. And I think that segues nicely, I think, into the first question that I'm going to put to the panel on social care. We've had a lot of questions on it already. Sally, I think you touched on this in your reflections, but Susie here has asked, do you think we'll still get the long-awaited green paper, or will this now be forgotten?
A really good question, Susie. So it won't be forgotten. Whether it's a green paper or not, I think, is a more interesting question, because if you think a green paper approach was first announced in March 2017, so that was quite a long time ago, and it might well be that this government thinks about tackling the issue in a different way, which might be a green paper, white paper, the classic route. It might be, actually, given that pretty much every model is known and out there, it might be that they do something that's more about discussions amongst Parliament about possible issues leading to a white paper. It might be that they actually engage much more directly with the public. So I'm much less fixated on, is it a green paper? Is it cross-party talks that must start within 100 days? I'm more interested in, do they look like they are actually going to grapple with the issue? And in that regard, I'm quite positive in that we have a government with a large majority that is looking to grapple with social care in its first 100 days, so right at the start of its term. We haven't had that set of scenarios since Tony Blair in 1997. So I think we've got a government that can take 4 years to come up with the right answer, legislate and implement, and that should give them confidence to be able to now be quite bold. So I'm confident it's on their to-do list. We will certainly keep up the pressure that they take steps forward, but I'm going to be quite flexible about what do those steps look like. It might not be a green paper.
But it sounds like, you know, for the first time in a long time, we have a government that has the tools within its gift to make a difference here. They now need to use them. So we'll be looking out for that.
Absolutely.
Yeah, absolutely.
Just thinking of the audience that will be tuning in and people who might download this, is there any message for leaders in health and social care about what they can be doing to respond to whatever the government's doing? Because there's one thing about waiting for policy and spending review and budget, but there's any practical things that we would advise people to be getting on with locally?
So I think, really good question. So I think that it's two kind of things. One is about we've got an agenda about improvement locally, which is to do with integration and joining up and thinking about the workforce locally. So I think really be playing a part in that.
Yeah.
So making sure integrated care systems and place-based working genuinely is health and care and not NHS is really, really important. But then I think there's also something about how the sector engages with potential future models. So no policy here is perfect. Every policy is quite complicated. If we hold out for perfect, we'll never get progress. So I'm kind of very much in the space of we've got to measure any new policy against, is it an improvement from the current system now, and how can it then be a building block going forward? So I think really helping government and parliamentarians really understand the opportunities and the challenges with models so it can be implemented successfully is also, I think, important.
So what I'm hearing there is kind of an iteration. You would say iterating and getting better, as opposed to thinking that we'll solve it all in one policy.
Absolutely.
Okay, thank you.
And another one for you, Sally. So you touched on this in your reflections at the beginning, but this is a question about the minimum wage. Yeah. So Chris Hand, thanks Chris for your question. How will social care deal with the new level of minimum wage when it comes into play?
A really very, very good question. And the simple answer is, I just don't know. The minimum wage increase is 6.4% on wages, and around 30% of social care staff are at or near the minimum wage. So this is a big increase on the wage bill and the cost of services. And to give an idea, the UK Home Care Association has recalculated what they think that means the minimum cost per hour is, and that's a 9% increase on the minimum cost per hour of domiciliary care. So these are really, really big increases. Unless the government provides more funding at a budget or in a kind of special event, inevitably it means that local authorities are going to be able to buy less care. Yeah. So this is going to mean that people needing care are not going to receive as much. I mean, because there is only one way that local authorities can go here. They can't overspend. They're legally required to balance their books. They will absolutely be looking at efficiency and innovation, but they've been looking at that for a decade and really been pushing that really hard. And fundamentally, providers need a certain number of staff to be able to be sure that they're delivering quality services to people that need it, and that will be the bit that potentially gets squeezed. So it's an absolute dilemma for local authorities, and government needs to explain how it sees this adding up.
Thank you. And Chris also added to his question what the impact might be for the NHS and its workforce. I just wondered, would it be helpful to just run through Siva, Susie, can either of you explain what happens there? Is that already factored in?
That's a good question. I don't know, to be honest, how much, if staff on basically I don't know how many staff on an Agenda for Change contract would be affected by something like the minimum wage. There is a parallel in that, you've got a new Agenda for Change funding deal, which will raise the staffing bill. And I suppose so having said I don't know, the similar dynamic to social care is, again, you've got a new government, you've got new spending promises, you've got budgets increasing, and that creates a dynamic, hopefully, of more services, new investment. And actually what you'll see is you're trying to make up an awful lot of lost ground, whether it's staff pay, whether it's investment in buildings. So all this money that's coming in at the top may not actually be apparent in changes to the services that are being delivered.
Yeah, may not deliver additional capacity. So I think you're right. Obviously, we have got that Agenda for Change new deal, but I think there's also something about the other services that provide to the NHS. So there might be people not directly employed through NHS pay terms and conditions, but so that could definitely affect. I think there's the other factor, which is at certain levels of pay, what are other employers offering? So we certainly know in social care, there's been people going off to retail that are paying higher, not because people aren't motivated to work in social care, but in terms of actually providing for your family. If you can get more money at Aldi, maybe that's a decision you have to take. So I think as well as the pay rate, there's also what else is going on in the market.
And I think that point's really important, Susie, because it's not only about what does the national minimum wage increase mean for staff at the bottom of the minimum wage, but there's also a differentials point. So actually, if government, even if they only fund the kind of increase for people at the bottom, what then happens is somebody's got 5-10 years experience, they can't increase their salary as well. So you find that there's not much differential to reflect experience, which then means people may well choose to leave the sector, and that can become a real risk. So lack of progression for careers in social care is already a known problem, and this can exacerbate it. And certainly what we've seen with previous national wage increases is that social care has become less competitive compared to other sectors of the economy, which feels a bit counterintuitive because you think surely an increase in minimum wage must be positive for everybody, but actually it's positive for parts of our workforce and more challenging for others.
Yeah. Great. And so obviously workforce and the impact of minimum wage on social care is a huge issue. But that does lead me to, we've had Susie, we've had quite a few questions on workforce. I want to turn to you now. So Rachel Warren from the Resuscitation Council UK, who's a policy officer. Hi, Rachel.
No relationship to me.
Oh yes, absolutely. Or is it your mum? Yeah. What can we expect to see in the People Plan on education and training? So a crystal ball question there, unless you've seen the draft. I guess you couldn't talk about it even if you had. But particularly, Rachel wants to know on the release of clinical staff from clinical duties so that they have time for training and CPD to help with retention.
Yeah. So excellent question. Very difficult with the crystal ball to know. There has been a huge amount of listening consultation that's been going on since the interim People Plan was published last year. So I think we can be confident that actually the arm's length bodies that are involved in pulling this together have been listening to what the professions have had to say about investment in CPD and time out to do CPD. Obviously, the proof of it will come in what money becomes available in the budget and fundamentally kind of later in terms of the spending review. There was a commitment in the Conservative manifesto to CPD. But we know that traditionally what happens when money gets tight in the NHS is that that's the first thing to go. Yeah. And it's often very difficult to get staff off shifts to do anything other than mandatory training. So I think it's a real dilemma. I can't sit here and say it's going to absolutely be solved, but I do have some confidence from the conversations that I have been involved in around the People Plan that there will be a strong commitment to that. I think the test of it is going to be how local leaders actually implement the People Plan, because it's one thing to set a policy direction and say we think CPD is really important, but fundamentally it comes down to the day-to-day management and the lived experience of staff. And what we know from the feedback that we get from staff is that there is variation in terms of people's experience. So some organisations very committed to the education and training of their staff, and you see that in their retention rates in terms of sort of low levels of turnover. But we have others where actually it's very difficult. And I think in those NHS organisations that are particularly in the most challenged environments, so kind of people who are sort of in special measures, CPD is probably the area that's going to be hit. So I can't say that it's going to go away once the People Plan's published, but I would have some confidence that people have been listening and taking note of what the professional bodies have been saying.
Yeah, great. It's back to all your work on culture as well, because the budget can and hopefully will send a clear message that CPD is important and the money's there to support it. But with the operational pressure you're under, I remember I was talking to a Band-Aid friend of mine at the NHS in a teaching trust, and I was saying, how's your CPD? Do you actually get time to go and do any CPD? And he said, I haven't even had an appraisal yet for 3 years working in this trust, let alone identifying what my training opportunities, let alone being able to go out and do them. So I think until the operational pressure eases, or you make a firm commitment that this is important to improve how you do your work, and it's part of the offer to staff that makes you an attractive employer in the NHS, you're going to get caught in this vicious cycle.
But we do know that it's critical to retention.
Absolutely. But you make a really important point there, Siva, which is, what do we mean by CPD? So, there are a range of things that we need to do to support staff to actually develop the skills, experience to effectively do their work. And some of that is external training, some of that is time out, practicing as a team. So there is something around how we free up staff from non-value adding tasks to make sure that there is a rhythm of CPT, so it isn't something that you just do as a one-off in a year, but it's actually seen as something that is throughout your working year.
Okay, so let's stick with culture. We've had a question from Carol Cook-Zara from Health Education England. She's a Darzi Fellow. Hi, Carol. And Carol has asked about the workforce race equality standard and the data there. So she's asked that given the data still tells us that in spite of increased diversity, the culture remains unchanged. How can we get better at creating a more inclusive culture in 2020? Susie, what are your tips there?
She's absolutely right. This is fundamentally, the reason I said workforce is because it's not about the numbers game, it's actually about the lived experience of staff, both in social care and in the NHS. And in fact, here at the King's Fund, we're currently doing some work to actually listen deeply to the experience of staff and black and ethnic minorities about what it's like working in the NHS. The RES data, yes, does show that there hasn't been anything like the progress that's been committed to previously. I think there are areas of the country that are doing better than others. Don't ask me to quote them in the meeting, but there are, we do hear examples of really good practice. The RES team that are part of NHS England and NHS Improvement are very committed to this and doing good work, kind of working with leaders, understanding what is making the difference. But I think it's fair to say that actually we think that there is action that's required at every level of the health and care system. This issue is unacceptable. The NHS staff survey shows us that the levels of discrimination that staff are experiencing, bullying, incivility are, just unacceptable for a service that's meant to be compassionate and caring and giving great care. So I absolutely agree with the question. Yeah. There's a lot more we need to do. It's not just about policy, it is about that day in, day out practice. And to go back to what I was saying at the start of our conversation today, we need to shift so that actually workforce culture actually comes to the top of the kind of national agenda, so that it's not something that is just happening at a local level. We need the right kind of leadership behaviours from the arm's length bodies on this as well. And I think, Prerna Rasar, who's the Chief People Officer, took part in a podcast recently where she explained her experience of going out on an ambulance shift, and she had racist abuse while she was out on an ambulance shift. That's happening to the Chief People Officer for England. It's certainly happening right across the service. So absolutely. Enough is enough. Yeah. And we all have a duty to be able to do whatever we can within the sphere of our influence to tackle it. But it's systemic, and it's not something that there's no single lever.
Yeah. And we're doing some work. We're doing our own piece of research here, I think, led by Shilpa Ross, one of our colleagues, who will be publishing later in the year.
But I think what's been interesting about that piece of work, so Susie talked about areas of good practice. Yeah. So when we looked at the data and kind of what improvements people have made, what we found is that some areas made improvements in one part of the RES, but actually kind of slipped back in other parts. What we couldn't find from the data was a compelling picture of, is there a place that is improved everywhere? So actually what that suggests is it really is a fundamental cultural thing, because you can focus on a process or an issue that can shift one indicator, but actually everything else drops. So hopefully the work we're doing, which will be published before the summer, will help boards at a local level and help national bodies really think through what's the leadership that can be delivered to really shift the culture to mean that people's experience improves. Because as Susie says, it's absolutely unacceptable that we have staff experiencing this. It's important to say, and this isn't just them experiencing it from patients, this is them experiencing it from the being employed in the NHS. They report a really, really poor lived experience of being employed in the NHS, and that, I think, is the kind of really, really devastating thing for our system.
Well, and we see that in progression as well, don't we?
Yeah. So I think we will see more on it in the people plan. Talking to Prerna, I absolutely believe we will. There's been a lot of work going on it. However, it is actually about the day in, day out experience of staff. So it's not enough just to have a policy lever. It has to be how it's being measured, how it's being supported, how it's being tackled when it's found.
Thank you. So Siva, I want to come to you now. It's your turn in the hot seat. We've had a question from Edward Cornick, who is a general manager at a foundation trust. I think he's been in to speak to us before.
He's a friend of mine.
Siva remembers that you're his friend.
Well, at the moment, he's a friend of mine.
So he's asking, what insight does the panel have, and I think we'll say it's you, Siva, on when and how centralised capital funds will be released, and how will they be distributed?
Ed. What insight do we have? Well, so let's start with the good news, which is infrastructure is a key priority for this government, and the Secretary of State for Health and Social Care has added it as his fourth priority for his term. So it's clearly important. We've got a health infrastructure plan that, on the face of it, does set out what the long-term future of capital funding is, and it divides into buckets of capital funding for buildings and equipment and whatever it is you want to do, that's a big capital bill, that's tied to your system plan. So you as a region in Bradford where Ed is, whatever it is you're trying to do in Bradford to improve care for patients and service users, that has a capital requirement. Here's a dedicated fund for you. Then you've got your usual routes of whatever it is you as an organisation within your four walls needs to do, you can draw down on it. The missing part of the picture is how much funding is on offer.
Yeah.
So all we know is there's the promise of up to 40 new hospitals to be built. What we don't know is what's the capital budget for the future years, and we don't know whether the funding for this 40 new hospitals, if it comes, is on top of existing plans for capital or is going to cannibalise those existing plans for capital. So that's a long-winded way of saying there'll increasingly over the next year, I think, be a clear line between capital funding for your own individual organisational projects versus capital funding for system projects, but where's the money coming from and how much will it be are the two big unanswered questions until we have a budget and a spending review.
And are we optimistic that we will see something in the budget, or are we thinking we're going to have to wait till the spending review?
I think you've got to I think you'll see it in the budget.
Yeah.
I think you haven't got that much time left to dither and wait for a spending review. And to be honest, there are not that many options over what you can do. You know, you've ruled out private finance as a source of income, so you don't have to waste time deciding where the money's come from. It's coming from public finances. So it's then just what does the economy look like, how much headroom have you got to invest. But I think you'll start to see a strong signal of intent in the budget itself in March.
Yeah, so the Treasury have already said they anticipate the budget being themed around infrastructure and investment. So it would seem quite odd, given they've already made some commitments to NHS infrastructure, to not firm that up. But I think Siva's absolutely right about the hospital position. I think it's just always worth mentioning when we talk about capital that hospitals are not the only things we need. So primary care capital, it's a real issue about whether the primary care estate, the primary care estate is not currently suited to the kind of multidisciplinary teams that we're envisaging with primary care networks. So that's a really significant challenge. Then in social care, we have a really, really old estate across our kind of care homes that will need to be replaced at a point in time. But actually, the cost of that has been sunken now for a very long time. So we're not reflecting the cost of capital in the amount of money we're paying for social care places. So that will become a real issue over the next few years for social care as well.
And you highlighted their primary care and primary care networks. I want to come back to those in a second, but before I stop with questions to Siva, let me just ask you another one. So this is a question, I feel that I'm slightly cheating by asking this one because it's actually from Ruth Robertson, who is on maternity leave from the King's Fund at the moment. Hi, Ruth.
Especially from a baby.
Yes. And the question is, Siva, and she specifically says for Siva as well, how is local financial management going to work when the government needs to show it's getting its money's worth for the extra money they're putting in?
Thank you, Ruth, for that question, and congratulations, by the way. So, how is local financial management going to work? To be honest, this is something that really, really worries me because even for our current financial year, which, and you know, we're in the middle of this new, well, at the start of this new NHS funding deal, the financial pressures in the NHS, particularly in the provider sector, aren't letting up. So cost improvement plans reducing your expenditure, proving really, really difficult because you've still got to pay premiums to get enough staff in to do the job, and income, for some reason, is behind plan as well. So I think we're going to end up with this really unhelpful situation of record sums going in of funding, and yet the NHS just about managing to balance its books. And that's balancing its books without investing in expanding services, hiring loads more staff, which are the sorts of things you would need to do if you're going to improve services. So I think this year, probably next year, the finances are still going to be on a knife edge. And I think the targets that were set as conditions for this 5-year funding deal, that no organisation will be in deficit by the end of the 5-year period, that the provider sector will start to tip back into balance, I think it's going to be really hard for those targets to be met.
So not particularly optimistic then?
Not particularly optimistic on those national aggregate targets, but in terms of, you know, really micro interpretation of Ruth's question, local financial management, I see two things that give me a lot of optimism. One, just an an increase, or actually not a letting up, in trying to stamp down on unwarranted variation. So you would think with the new 5-year funding deal, do we really need to worry about variation in the procurement of drugs? Do we really need to worry about the variation in our costs? And I'm seeing the opposite. I'm seeing more and more interest in detailed granular data that shows you where waste can be reduced. Yeah. And the second thing that makes me optimistic is the number of organisations that are talking to each other to say, how can we work more closely, whether it's through an integrated care system or an STP, to share financial risk and do things differently in a way that would have been really hard to do 5 years ago or even more recently than that.
I think that final point, kind of almost everything comes back to culture. So actually the rules currently require a chief financial officer to balance the books for their organisation, but they may well recognise that they need to do something different for the system or the local health economy. So it's about how have they got the culture and the behaviours and the relationships locally to be able to, as an individual organisation, the board, be confident that doing the right thing for the system is the right thing for the organisation, and that takes a lot of effort at building those relationships. But it's fundamentally about the culture of what are we all trying collectively to do, what's the right behaviour that drives that, rather than what's the rules that kind of tell us to do X, Y or Z.
And as an ex-director of productivity and efficiency, I think what I can say is that you've got passion in the service for driving value, for making the right clinical decisions, for reducing variation, but you need to have the skill set and the headspace, to go back to one of our previous questions, to do it. So I think we've got a kind of a change that's happening in terms of improvement skills and kind of how multidisciplinary teams can actually address some of how they actually do the reducing variation. But there's still a long way to go. Talking to Hugh McCahey, who's the National Director of Improvement at NHS I&E at the moment, developing a new national framework for improvement, there is a recognition that there's still a lot to do in terms of capability and capacity within the workforce to actually capitalise on that data, if that makes sense.
Thank you. So we're getting some great questions coming in, and here, this particular one, I think for now wins the award for brevity and clarity. So this is from Robert Neal, who's at North East London Foundation Trust. He's a business development lead there. Hi, Robert. And he's asked, do you think primary care networks will have a positive impact? I don't know, Sally, Susie, which of you would like to, or do you both want to go for it?
What do you think, Sally? I think
so where to start with this? I think they have the potential to add value. So I think the principle behind them about having stronger primary care teams with different skills in them to be able to kind of meet the local needs of the population in a different way that isn't so reliant singularly on GPs. I think that's really positive, and we saw a lot of enthusiasm from GPs last year. Unfortunately, though, you can't talk about primary care networks at the moment without talking about the DES specifications.
To spell out DES.
Direct enhanced services.
Yeah.
And what this did for people who haven't been following it kind of step by step is this set out as part of the contract negotiation 5 very highly specified requirements on GPs to deliver as part of the primary care networks. And there has been genuine concern from the GP community about their ability to deliver that. So the extent to which there's capacity in the GP workforce to be able to deliver it, whether it's right to have that level of national top-down specification. And you can look at that and think it's a technical debate about a contract, but more fundamentally you can look at that and go, this has the potential to turn off GPs from a model that they 6 months ago were very excited about, their ability to connect to local services in a really profound way. So I was on a visit last week to Sheffield, and I was really impressed that kind of every session I went to, there were GPs in some form of clinical managerial role who were talking really, really passionately about how they could see primary care supporting the network and supporting outcomes. But when you then talk to them about the DES, just their kind of everything kind of drooped, and it's really absolutely not what we wanted. We absolutely cannot see how it works. And I think it's not just a technical debate. There's a bit about to what extent have you got GPs' hearts and minds now behind this. So I think it's a delicate stage.
Yeah, I think you've captured it. I mean, fundamentally, the kind of how could you argue against the principles of people working in effective networks, looking at workforce redesign, a much more joined up, shared responsibility, ownership for redesign. I'm fortunate to live in the city of Sheffield. There's some amazing primary care work going on there, and much better relationships in the 10 years that I was working there between local acute services and primary care, really learning from what primary care were doing. So I don't think you can argue against the principle of the networks, but the problem is you can sometimes get unintended policy consequences of the kind of mechanistic things that need to be in place that are turning people off. And I think, as you say, if we lose the kind of hearts and minds of people who are so passionate about improving care for their local communities, then I think that is a fundamental problem. We need to make sure that actually the principles are still in place, and that policy leaders are listening to GPs and GP leaders and the relevant organisations.
Absolutely. And Sally, you mentioned there that the service specifications, the 5 specifications, had caused some kind of controversy among the GP community. I just wondered, because obviously the country has just elected a government that had in its manifesto a commitment to improve GP access. To what extent, from your perspective and from the rest of the panel, do the service specifications and the kind of the plan for primary care networks progress that agenda, or is the agenda on primary care networks at odds or in conflict with the commitment to improve GP access currently?
That's a really very good question, Helen. This is where it actually gets really interesting, because obviously the government's agenda on primary care is quite access based. So it's 50 million more GP appointments. They haven't introduced a kind of access target, but I wouldn't completely rule that out from the agenda over the next few years. Whereas the primary care network, most of the specifications have been about how to improve, if you like, the quality of care being provided. So whether that's about GPs' engagement with people who are resident in care homes, whether it's about medication reviews. The theory of primary care networks is that by having more GPs and more other specialist staff, that you do free up capacity to mean that access to a primary care professional is more easily available. So it should be possible for the two to sit side by side. And part of the issue with the DES specification is GPs really concerned that actually you wouldn't have freed up enough GP capacity to be able to do all of that yet. So in effect, you're asking GPs who are already massively overworked to spread themselves too thin by those requirements coming in before the extra workforce, and the skill mix has really delivered the intention.
And to compound that, what we're hearing is also that the trainees that are now coming, so GP trainees that are coming out, in terms of the numbers of them who expect to stay in the service, those figures are looking worrying. So you've got the existing GPs who are kind of full-time in the service, and then the pipeline is looking like there is a big gap in terms of GP time. So I think it's really difficult.
And that actually takes us neatly onto our next question from Gemma Griffiths from Help to Change CIC. Hi Gemma, she's the Chief Officer there. And she's asking about GP numbers. So how will the government address the lack of GP numbers in primary care, and how long will this take to come into effect? Susie, do you want to take that one?
I mean, I think we know that the current target will not be met. So I think everyone's accepting that the current target won't be met. Obviously, we're expecting the NHS People Plan to really focus on numbers as well as culture, leadership and all the other things that we've mentioned today. So we should see some further commitments in the NHS People Plan. But given the lead-in time to train people, there is something we really need to do fundamentally about the skill mix in primary care. So yes, it's about GP numbers, but it's also about what other professionals working in primary and community care can do, and how we recruit and retain numbers of them as well. So it's the whole mix. So yes, pipeline is important, but retention, I would say, is where a lot of emphasis needs to be placed.
I completely agree, because actually the numbers in training have inched up a bit, but the numbers of GPs hasn't, and that's because I think we need to recognise in our workforce planning what's the career that people want now when they're moving into being a GP. And as you mentioned earlier, Susie, it's increasingly clear that people training to be GPs do not expect to work full-time as a GP. They are going into that profession partly because of the type of clinical practice they get there, but also because it allows them to mix it with research, with other types of using their medical skills. So actually, one GP in training is no longer equating to one GP practicing, and that is something that we've really got to fundamentally address if we're going to have the right pipeline.
The latest figure was something like 27% of
trainees
expect. I think it's 27% of trainees say that they expect to be full-time and working as a GP after a year. 27%, I mean less than a third. So real issue. And as you say, but that ought to, or being more positive, make us think about what is a career and how to give flexibility, and how do we get a greater movement in the NHS, so people have the opportunity to have a career that has maybe more of a portfolio than just a single role in a single institution or a single part of the system. But that requires a massive cultural change.
So Siva, I want to come back to you, and this is a really good question. It's about where should the money be spent. So a question from Rachel Grant from the MS Society. Hi Rachel. And she's asking, should the budget focus on areas of greatest deprivation that often have the worst health outcomes and poorer health and care services? And Sally, you may have things you want to input there, but Siva, let's start with you.
Yeah, so I think if you've got more money coming into the system, one of the purposes of that is to improve the outcomes of the population. And if you follow that logic model, probably one of the best things you can do to improve the outcomes of the population as a whole is to reduce health inequalities. And there are existing mechanisms for doing this. So how much money you get as a local region, as a clinical commissioning group, will depend on the needs of your population, including things like the disease burden as well. So I think there's one way to do it, which is quite passive, just push the money through the system in quite an untargeted way and hope it reaches the communities who need it most. The other thing would be, are there a few things you can do that are particularly targeted on individual disease groups or particular parts of the country? And that's why I think the budget will be really interesting, because it meets this agenda item of levelling up. And do you do something that goes beyond what the formula would tell you need to spend in regions like the North or particularly deprived communities, both to have a genuine impact on health outcomes, but also to send a signal of you're a government for all regions. I don't know if they'll go there in the budget. That's quite a short period of time to throw a lot of the funding formulas up in the air. I think that's the sort of thing you might see more in the spending review, coming alongside things like a review of business rates, which tangentially touches on that issue as well.
Yeah. I think that's absolutely right about NHS spend. I think it's also worth thinking about the type of spend to tackle the outcomes that were being discussed there. So actually, the NHS, as much as it's the beloved institution of the nation, actually isn't the thing that makes the biggest difference to our health outcomes. There's a whole set of wider determinants which are predominantly in the kind of accountabilities of local government, in terms of it's your schooling, it's your local environment, it's access to green spaces, it's the kind of quality of housing, it's the quality of job you have. If you're serious about levelling up, you've got to be serious about that wider determinants agenda, and that's got to be locally led, but it's got to really address those structural issues around all of those wider determinants. So this isn't just about allocation methods within the NHS, it's also about thinking about the balance of spend, and that's where I think it's spending round territory, where you're rethinking the balance of spend between different services rather than a kind of infrastructure heavy budget.
The other things I'd add into that mix is obviously parity around between mental health and physical health. I think what's going on in devolution is very interesting at the moment. And then I think, we've seen through some of the work that we've been doing at the fund, areas that have been subject to cuts. So thinking about Wigan, thinking about some really nice work, great work that's going on in Fleetwood, where the local community are being actively involved in the redesign of services. So actual citizens, leaders, working along to make improvements. So I think it isn't just about where the money's pushed, it's actually about the how, isn't it, what you actually do with it locally.
So we haven't yet spoken about digital and technologies, and we have had a couple of questions on that. So Siva, I want to put this one to you. It's from Stefano Palazzo at 2020 Delivery. Hi, Stefano. And he is asking, so we know that Matt Hancock is a strong advocate for the use of digital and novel technologies in healthcare, not least, he says, in the formation of NHSX. So he wants to know, Siva, do you see any big changes to how the NHS is going to be using digital and technology in the coming year?
So I wouldn't say it's a big change, but one subtle change is what we talk about when we're talking about digital and healthcare in particular has changed from a focus, perhaps a disproportionate focus, on things like artificial intelligence, machine learning, what you could crudely call the sexier edge of technology, to things that are a bit more of the fundamentals thing. When I go out and talk to people about digital and healthcare technology, it tends to fall into two camps. There's the big long-term strategic electronic patient records married with data from councils to understand the needs of your population, so you can think about how you deliver services differently over the next 5 to 10 years. You know, where's the real need and how can you get new insight into that from joining up different data sets? So that's one area. And the second area is almost really operational things about how you run a healthcare organisation. So Milton Keynes have been talked about a lot for how they're using technology to change the relationship people who have outpatient appointments have with the ability to book appointments. You go to Royal Wolverhampton, how that hospital is run is completely different thanks to the use of technology and teletracking kit. And I think people are starting to talk about that more rather than things like machine learning and AI, which are really important, but are only one part of the discussion.
Yeah, I would agree. I think having worked also operationally a long time in the NHS, I think we're seeing a shift of the conversation. I think what we need to do is actually be talking to all staff about what it means for them. So how do we support a digitally enabled workforce? So to understand all those implications. And you've cited some really good practice, and I think we are seeing that across the NHS, but I'm not sure it's universal. And I still think for a lot of staff that are working day to day, they see systems that don't talk to each other, or they see no system at all. So it's kind of how we raise the level of conversation about where digital can really support and actually reduce non-value adding tasks that at the moment we've got quite expensive staff running around to do things.
I think that's where for this year we're likely to see the focus on some of those, the basic hygiene factors, which then allow clinicians and other staff to be freed up a bit more. So I think that kind of it supports the workforce agenda, it supports the increasing capacity agenda. It also gives people confidence that the sexy stuff being talked about, we're actually going to be capable of delivering. Because I think for staff, if they're kind of stood in front of a computer and it's taken them 30 minutes to log in, I think they find the idea that everything's going to be run by an algorithm in 3 years' time quite implausible, because their experience of tech is quite poor. Yeah. So I think improving some of those basics is going to really help.
I think let's not underestimate what it actually takes to bring in new technology into the NHS. We don't have a great history of doing it, and at the planning level in an individual institution, it's very difficult, and the change process is difficult. So I think we've got to get better where there is a piece of kit or an approach that's going to really work. We've got to get smarter about how we actually implement and scale that in the NHS, because at the moment I think it's too institutionally led.
Yeah. To be honest, it's one of the things that makes me most optimistic in the coming year, that we are focusing more on how can technology improve your day-to-day existence as a patient or a staff member. I was shadowing a general manager at a large teaching trust, and we were sat with the acute medical consultants, and the sort of ripple throughout the room when the chief clinical information officer said, we're piloting this new scheme that helps you log in about 14 seconds compared to 9 minutes. It was like they'd announced another public holiday. It was just, thank you for doing something that makes my life a little bit easier. So I am optimistic. One question will be, I've forgotten his name, sorry, who asked the question? Stefano. I'm clearly the only one who forgot his name. So it is incredibly personally tied, this agenda, to the current Secretary of State for Health, and we're approaching a reshuffle. So I hope that the agenda, the digital agenda, stays as prominent and is not tied to an individual. It's part of the way you do business in the department downwards.
Yes. Although if it was to shift, we'd need to get rid of NHSX, right, which has only recently been set up. I know that's not impossible and things change, but yes. So just sticking with that theme, or somewhat related, so there's a question from Gareth Whiteley from Guernsey. He works on digital transformation, and he's asking about service users owning their data. So he asks, what's the wind of change, Siva, regarding service users owning their own data? Are the likes of the NHS app and access to the summary care record the first steps towards full ownership of your own healthcare data? A big question.
Yeah, I think both here and probably if you look at other countries, you look at the States, you look at some of the Scandinavian countries, they seem further ahead. But that's definitely the direction we're moving in, of you being, as a service user, as a patient, being the repository of all the information. And I think a lot of the antibodies that were out there about power and who holds the information seem to be going away. And I think one of the trusts that's really pioneering this, I don't want to name them just in case I'm putting them out on a limb, but one of the things that really helped the board work through things like the data governance issues or the clinical accountability was when one of the clinical directors said, but look, a lot of these patients my patients have it written down already.
Yeah.
You know, if you're a patient with dementia, your carers have a lot of this information written down in a book that is with you at all times. This is just a digital equivalent of that. It's good care. So I think that's clearly the direction of travel. How quickly we will get there, I think that's a really difficult question.
I was going to say, just as you were saying that, if you came to my home fridge, my son's got a long-term condition, and you had a look at the letters that are currently held by magnets on that fridge, there's pretty much all the information that would be held on the hospital system, because now the amount of data that is shared with us in written form from his clinicians. So I think it's a less of a barrier to get over than in the past, except that there are kind of various hurdles in terms of governance that need to be dealt with. But I think we've got to shift to that. We should see a change in that in the next 5 years.
So we've got 5 minutes left, and I'm aware we've spent quite a bit of time. We've talked about some positive opportunities and things that are potentially good and exciting, but we've also spent a lot of time talking through our kind of views on risks and concerns over the course of 2020, and it would be nice to end on an optimistic note if possible. So I'm sure that each of you have something you're looking forward to seeing over the course of the next year in a health and care setting, not personal. So it would be great to just get a few final thoughts from each of you, I guess quite brief, in terms of what you see as the greatest opportunity in the year ahead. Let's start with you, Sally.
Thanks, Helen. So I think for me, the greatest opportunity, and I might cheekily do 1.5, is I mentioned it kind of near the start. So I think this is a different opportunity for social care reform than we've had before. I have been kind of optimistic, pessimistic, kind of really hopeful at lots of different times over the last 15 years. But this does feel like it is a different point in time. It's the beginning of a parliamentary period with a large majority. So I am hopeful we will see a plan that will improve the current situation. And then I think my half a bit is I'm also, when we see what happens about locally led improvement, it's absolutely inspiring what communities are doing with people working in health and care. So I'm kind of very optimistic about the skills and passions of people who work in the health and care system, and how they work alongside communities will mean we will see some absolutely amazing things that happen in patches, and what we need to be doing as a system is helping that kind of learning be shared more. So yeah.
And we play a role in doing that.
You do.
So a task for us as well. Siva.
So for me, it's about power. The more and more time I spend around the health and care system, I get really interested in power. And I see changes in how it's being used and how it's being thought about. So I read a cracking document called Joy in Work, Self-Rostering, which it's a page turner. But it was all about, you work in an intensive care unit, you're a nurse. Why not be able to set your own working conditions? Do you want to do night shifts? And at its heart, it's about power. It's rather than someone setting a rota and saying, guess what, you're missing your cousin's wedding because you're working the shift. It's, we trust you to manage your work, and we will have a full rota at the end of it. Things like that, things like the Milton Keynes outpatient app. You know your life better than us, so you're in control of that. System working where there is no positional authority at the moment. The only way you can get anything done in an integrated care system or STP is by sharing power, because no one's really in charge. I think the different way that power is being thought about and used in the healthcare system is something that makes me optimistic.
And actually, before we move on to Susie, because I just realised you talk about positional power, and currently, in an ICS there isn't any. I guess just a quick thought from you on, are you looking forward to the legislation that may come in to support the long-term plan, and what that might do to shift the dynamic you're talking about there?
Yes and no. So yes, because if the legislation codifies a lot of what is already going on but feels like you're breaking the law in doing the right thing to collaborate to improve services, yes, to that extent. I think the downside is not having positional authority and positional power means that at the moment, in the way it should work, is that the integrated care system or the STP works for you. It's there as a mechanism to help you as an organisation deliver better services for patients. You don't work for it. So I'd be very wary of anything that dramatically changed that dynamic.
Thank you. And Susie?
Yeah, so I got hope and optimism around the workforce in terms of it being right at the top of the agenda now, and I don't think that's going away given the size of the challenge both in the UK and globally. And I'm excited about, within that, the kind of recognition that culture, leadership practices are the things that really make the difference. So those are things that within our gift don't need money, don't need a budget. But that doesn't mean we need some change at the centre. And I guess it probably builds on Siva's point about power, is that we've got several generations now working in health and care, and actually see the passions of young people coming into health and care is, you know, like magic. And so we need to find ways in which we better support them to work in those services. And also, I think there are generations coming through now who won't tolerate the kind of working practices that we've seen for the last 10 years. So I feel optimistic about that. And when you spend any time with people who are in training, the passion they feel for the work they're doing is the thing that keeps me optimistic. And I think fundamentally, hope and passion for what you do is critical if we're going to get any change.
Well, thank you. It's great to be able to end on a note of optimism. So thank you, first of all, to the panel, Susie Bailey, Sally Warren and Siva Anandasiva, but also thanks to all of you for tuning in and submitting your questions. You've enabled us to have a really great discussion today. We did have a lot of questions, so I apologise that we haven't been able to answer all of them. But just to flag again, if you do want to know more about what we think on some of the topics that we've discussed today, please visit our website where we have lots of very interesting resources. And this session can be viewed on demand after we end. I think it will be up in a couple of days, so please do share with any colleagues that you think might be interested, or watch again if that's what you want to do. And if you just can't get enough of us, another option might be to sign up at one of our Health and Care Explained events, and the next one of those is actually here in London next Thursday, and I'll be speaking at it, as will Siva and Sally. So you can see us all there if you want to. So hopefully we might see some of you there. And thanks again to all of you, and do please join us again for our next online event. Thank you and goodbye.